Okay, let's unpack this. Close your eyes for a second and just take a breath. Think about everything that has to work perfectly, just for that simple fundamental act. The ribs moving, the diaphragm flattening, air flowing in, tiny air sacs exchanging oxygen. It's an engineering marvel inside your chest.
Yeah, it really is.
This incredibly intricate space, the thorax, it's home to some of your most vital organs, right? Protected by the bony cage of the ribs and sternum.
Absolutely.
And when something goes wrong in there, whether it's, a simple air leak, a complex infection, or something as serious as cancer, it requires an astonishingly deep understanding of this internal world, precise assessment, and often highly skilled surgical intervention.
That's absolutely right. The thorax might seem like a static box from the outside, but within those boundaries lies a dynamic vital system. The respiratory system, the cardiovascular pathways, critical nerves, the esophagus, they're all packed in there, intimately interconnected.
Right.
A problem in one seemingly small area can have profound and cascading effects on everything else.
And that's exactly what we're diving deep into today. Our guide is an incredibly detailed, expert look at the thorax and chest surgery, drawing from a comprehensive surgical text. This source gives us the kind of granular insight that, frankly, the experts in this field rely on.
Our mission here is to go deep, really deep. We want to break down the fundamental anatomy and physiology, understand how professionals assess fitness for complex surgical interventions, explore the cutting edge and traditional investigations used, and then delve into the surgical management of various thoracic conditions, from pneumothorax to lung cancer, mediastinal tumors, and chest wall issues.
Yeah.
The goal is for you to come away with a clear, comprehensive understanding, a true command of the material, almost like you've been training alongside those elite professionals who tackle these challenges every day.
Exactly. This isn't just a surface-level overview. We've got a wealth of information here, tailored for you. Whether you're preparing for something specific, you're in a related field and need to truly master these concepts, or you're just driven by that pure, essential curiosity about how this vital part of your body works and how surgical science steps in when needed. So let's dive in. Let's unpack this, starting with the incredible journey of how those lungs even come into being.
Okay. To truly understand the adult anatomy, it's incredibly helpful to look back at its development. It starts astonishingly early, right around the 4th week of intrauterine life, when the lungs appear as a simple outpouching from the primitive foregut.
The gut. Wait, so the lungs start off connected to the digestive system. That's fascinating. It's not what you'd intuitively expect.
It is surprising, isn't it? This initial bud then develops into a structure with 2 main lobes. The fundamental lobar arrangement, how the lung is divided into these major sections, is defined quite early and remains fairly constant throughout development and into adulthood.
But the source makes a point about variations being common.
Yes, that's a critical detail for anyone looking at real-world anatomy. While the major lobes are consistent, minor variations in the fissures that separate those lobes and in the individual segments within the lobes are very frequently seen in adults.
Ah, okay.
This is why radiologists and surgeons pay such close attention to detailed imaging. These variations matter when planning precise procedures.
Speaking of early development, how about the blood vessel drainage?
Initially, the primitive lungs drain into structures called the cardinal veins. These eventually mature and reorganize to form the pulmonary veins, which, as we know, are unique because they carry oxygenated blood from the lungs directly back to the left atrium of the heart.
And venous drainage variability is also common, the source notes.
Very common. The pulmonary venous return can have many different patterns. Fortunately, in the vast majority of cases, these variations have little to no functional significance. It's just an anatomical quirk, really.
But there's a severe end to that spectrum you mentioned.
There is. The source highlights total anomalous pulmonary venous drainage. This is a significant congenital defect where, instead of draining into the left atrium, all the pulmonary veins connect back to the right side of the heart.
Oh, wow.
This means oxygenated blood is just recirculating back into the lungs or mixing with deoxygenated blood, and the body isn't getting the oxygen it needs. It's a serious condition that presents very early in infant life.
Okay, let's move from those developmental origins to the fully formed adult lungs. We always hear about the left lung having 2 lobes and the right having 3.
Right. The left lung is simpler, divided by a single oblique fissure. This fissure runs more vertically than horizontally, which is why the upper and lower lobes can sometimes be thought of as anterior and posterior portions.
And the right side adds an extra lobe.
Precisely. The right lung also has an oblique fissure separating lower lobes, similar to the left. But the upper portion on the right is further divided by a horizontal fissure, creating the upper lobe and the middle lobe.
And then there are the segments. The source mentions figure 60.1 concept showing these connections.
Yes, and this is where the surgical detail really comes into play. Each lobe is further subdivided into bronchopulmonary segments.
Right.
The crucial point, the detail that makes segmentectomy possible, is that each of these segments has its own distinct and named bronchial connection, its own air tube, and its own specific pulmonary, arterial, and venous blood supply. Think of each segment almost like its own little functional unit within the larger lobe.
So a surgeon can target and remove a specific segment if needed, preserving the rest of the lung.
Exactly. Understanding that discrete anatomy, tracing those specific bronchial and vascular pathways, is fundamental for planning precise lung-sparing resections, particularly in areas like cancer surgery. It's the kind of detailed knowledge that defines expertise in this field.
What about the bronchial tree itself, the airways leading into the lungs? There's a well-known anatomical difference between the right and left main bronchi.
This is a classic point, often illustrated conceptually, like in figure 60.2, because it has direct clinical relevance, especially in fields like emergency medicine and pediatrics.
Okay.
The right main bronchus is shorter, wider, and takes a more vertical path down from the trachea. The left main bronchus is longer, narrower, and angles away more horizontally.
And that difference explains why inhaled foreign bodies are more likely to end up in the right lung.
Precisely. Gravity and airflow mean foreign objects, like a peanut or a small toy part in a child, are far more likely to take that straighter, wider shot down the right main bronchus.
Wow.
It's a simple anatomical fact with potentially life-saving implications in terms of diagnosis and retrieval.
Where do the trachea and main bronchi get their blood supply? Is it part of the main lung circulation?
Interestingly, no. The trachea and bronchi receive a systemic arterial blood supply. It comes via the bronchial arteries, which typically arise directly from the thoracic aorta itself. This is distinct from the pulmonary circulation, which is dedicated to gas exchange in the lung tissue.
Let's talk about the lymphatic system within the chest. The source says the lymphatic drainage is critical for lung cancer staging.
This is where it gets really interesting, and it's absolutely crucial for any professional dealing with lung cancer. The lymphatic drainage tends to follow the bronchial tree.
Okay.
The lymph nodes within the thorax are meticulously named and organized into specific numbered stations and zones, as illustrated conceptually in figure 60.3.
Why is this numbering system so vital?
Because understanding these pathways and the specific numbered stations is the key to understanding cancer spread within the chest, and often determines if a tumor is surgically curable. N1 nodes are those right near the lung root or within the lung substance itself, stations 10-14.
Got it.
But it's the N2 nodes, the mediastinal lymph nodes on the same side as the tumor, stations 2 to 9, that are particularly critical. Finding cancer cells in these N2 nodes often means the disease has spread beyond what can be easily removed with surgery alone, impacting prognosis and treatment planning significantly. This mapping isn't just academic. It's make-or-break information for determining the optimal treatment strategy, which is why accurate lymph node staging is paramount.
So knowing the status of these specific numbered nodes is essential for predicting the outcome and deciding on surgery.
Absolutely. It's the roadmap for potential cancer spread and dictates the extent of both lymph node dissection during surgery and whether surgery is even the right path compared to other treatments.
Moving from structure to function, let's get into the mechanics of breathing itself. What are the primary muscles that drive this constant process?
The primary muscles of respiration are the intercostal muscles located between the ribs and the diaphragm, the dome-shaped muscle at the base of the chest cavity.
Okay.
When the intercostal muscles contract, they lift the ribs up and out, increasing the transverse and anteroposterior dimensions of the chest.
And the diaphragm.
The diaphragm contracts and flattens downwards, significantly increasing the vertical dimension of the chest cavity. These actions work in concert to increase the overall volume inside the thorax.
Are there accessory muscles too?
Yes, accessory muscles like those in the neck and spine, such as the sternocleidomastoid muscles, are typically only recruited when you need to take a very deep breath or when breathing is difficult due to exercise or illness.
Right.
Normal, quiet breathing primarily uses the diaphragm and intercostals.
What happens physically during inspiration?
As the chest volume increases due to muscle contraction, the pressure inside the chest cavity, the intrathoracic pressure, falls below the pressure outside, atmospheric pressure.
Okay.
This pressure difference creates a gradient, causing air to flow into the lungs until the pressure within the alveoli equals the atmospheric pressure.
And expiration.
Normal expiration is a largely passive process. It relies on the elastic recoil of the lung tissue. As the respiratory muscles relax, the lungs naturally return to their resting volume, pushing air out. Forced or vigorous expiration, like blowing out candles, uses additional muscles, particularly the abdominal muscles, to push air out more forcefully.
The source highlights the importance of a vigorous cough, especially after surgery. Why is that specific action so vital?
Clearing secretions from the airways is absolutely critical, especially after procedures that might impair lung function or involve anesthesia. A vigorous cough is the body's main mechanism for this.
Right.
The description in the source is fantastic. It notes that the diaphragm is actually relaxed during a cough, which, as you noted earlier, seems counterintuitive.
It still does. If the diaphragm flattens to breathe in, wouldn't it push air out when it contracts?
That's the key difference. During a cough, the diaphragm is indeed relaxed. What happens is you take a deep breath in, then forcefully contract your abdominal muscles, chest wall muscles, and accessory muscles. You brace yourself, clenching your fists, tightening your core, building up enormous intrathoracic and abdominal pressure against a closed glottis, the opening to the voice box.
Right.
Then the glottis suddenly opens. That built-up pressure is rapidly released, and because the abdominal muscles are contracted, they push the relaxed diaphragm sharply upwards, almost like a piston. This combination creates a sudden, high-velocity blast of air that can dislodge and expel mucus.
The piston analogy. That makes the force clear. It's about building pressure behind a closed door, then blowing it open with force, rather than just a simple squeeze.
Exactly, and being able to do that effectively is paramount for preventing complications like pneumonia after chest surgery.
Okay, so we've explored the structure and the fundamental mechanics. Before anyone undergoes major thoracic surgery, like lung resection, there's a significant assessment process. The source emphasizes a tripartite risk assessment model, recommended by the British Thoracic Society.
Yes, this model, conceptually outlined in Figure 60.4, is what professionals use to make informed decisions. It's a comprehensive approach that looks at three key areas of risk for patients facing major lung surgery: the risk of operative mortality, death during or shortly after surgery, the risk of perioperative myocardial events, heart problems around the time of surgery, and the risk of postoperative dyspnoea, significant breathlessness after surgery.
Let's break down the operative mortality risk first.
The most widely used tool for estimating this risk is the thoracic surgery scoring system, or Thoracar score. The source calls it the most robust model available for predicting death risk in thoracic surgery patients.
What factors go into the Thoraco score calculation?
It uses 9 variables: the patient's age, their sex, their ASA physical status score, a grading of their overall health, their performance status, how well they function in daily life, their degree of breathlessness, the urgency of the surgery, emergency versus elective, the planned extent of the surgery, how much is being removed, whether the diagnosis is cancer, and a score accounting for other existing health conditions or comorbidities.
That really drives home that it's not just about the lung problem, but the entire patient's resilience. What about the risk of heart events?
Assessment for cardiac risk starts with standard medical practice: a thorough history, physical examination, and a resting ECG. If there's suspicion of an active cardiac condition, the recommendation is clear: a full cardiology evaluation is needed.
And optimization before the chest surgery.
Absolutely critical. The source states the patient should be optimized medically, potentially with procedures like stenting, revascularization, or even cardiac surgery, before proceeding with major thoracic surgery.
Right.
There's also a specific time recommendation. Avoid thoracic surgery within 30 days of a myocardial infarction, heart attack, to allow the heart muscle to stabilize.
That makes perfect sense. You need the heart to be in the best possible shape. The third area, postoperative dyspnoea, seems uniquely relevant to lung surgery.
It is. While any general anesthesia requires some assessment of breathing function, lung resection intentionally reduces functional lung tissue, so a much more detailed assessment is necessary to predict the impact on the patient's ability to breathe comfortably afterwards.
This leads us directly into the tools used to investigate the respiratory system, especially pulmonary function tests, or PFTs?
PFTs are the cornerstone of assessing respiratory capacity. They're used to determine a patient's functional capacity, the severity of any underlying lung disease, and can even help predict how they might respond to treatment.
Okay.
They range from simple tests done in a clinic to more complex ones needing a specialist lab.
Spirometry is mentioned as the most common PFT.
Yes, spirometry measures the volume and/or the speed of air a patient can inhale and forcibly exhale. Results are compared to predicted normal values based on demographics like age, sex, race, and height.
The source highlights specific parameters measured in spirometry shown conceptually in Figure 60.5. Let's look at peak expiratory flow rate, PEAFR.
PEFR is the maximum speed of airflow during a forceful exhalation after fully filling the lungs. It's quick and easy to measure with a peak flow meter, but its accuracy depends heavily on patient effort and can be affected by factors like pain. It's commonly used in managing asthma, but a low PEFR can also suggest problems in larger airways.
Then there's forced expiratory volume in 1 second, FEV1.
FEV1 is the amount of air a person can forcibly exhale in the first second of a forced breath. This is a really important number. It's typically significantly reduced in obstructive lung diseases, where getting air out is the primary problem. However, a normal FEV1 doesn't guarantee good overall lung function, as it doesn't tell you about gas exchange.
And forced vital capacity, FVC.
FVC is the total volume of air that can be forcibly exhaled after taking the deepest possible breath.
The ratio of FEV1 to FVC seems particularly important for diagnosis, based on Figure 60.5.
Absolutely. The FEV1-FVC ratio is a key diagnostic nugget from spirometry. It helps distinguish between obstructive and restrictive lung disease.
Right.
A low ratio, usually less than 70%, is the hallmark of an obstructive pattern, where airflow is limited, often seen in conditions like asthma or emphysema. The source notes that if this ratio improves after giving a bronchodilator, it suggests reversible obstruction, typical of asthma.
And if the ratio is normal but the overall volumes are low?
That pattern, a normal ratio above 80% but reduced FEV1 and FVC, proportionally points towards a restrictive pathology, shown in Figure 60.5 tracing.
I see.
Here, the problem isn't airflow obstruction, but that the lungs can't fully expand or hold as much air, making them stiff, as happens in lung fibrosis. Table 60.1 in the source provides a neat summary of these patterns. Understanding this distinction is fundamental to diagnosing lung problems.
That really clarifies the difference getting air out versus lungs filling up.
Yeah.
Beyond spirometry, the source mentions diffusion capacity, DLCO. What does that measure?
DLCO, or transfer factor, measures the lung's ability to transfer gases, specifically how well oxygen moves from the air in the alveoli across the alveolar capillary membrane into the blood.
Okay.
Unlike spirometry, you can't do this at the bedside, and it requires knowing the patient's hemoglobin level.
And why is this test critical?
Because it directly assesses the integrity of the delicate surface area in the lungs where gas exchange actually happens. If the alveolar walls are damaged, like in emphysema, or the membrane is thickened, as in lung fibrosis, the transfer of gases is impaired, and the DLCO is reduced. This is a key determinant of fitness for lung resection surgery, because you need to know if the remaining lung tissue will be capable of adequately oxygenating the blood and clearing CO2. The source stresses it should be formally measured.
So DLCO tells you about the quality of the lung tissue for gas exchange, whereas spirometry tells you about the volume and speed of airflow.
Exactly. They measure different but complementary aspects of lung function, both vital for surgical planning.
We also commonly measure oxygen levels non-invasively with a pulse oximeter, SpO2.
Yes, SpO2, or oxygen saturation, is a quick way to check the percentage of hemoglobin saturated with oxygen. It tells you about oxygenation.
But the source points out a significant limitation with SpO2.
This is a crucial clinical nugget that professionals understand intimately. SpO2 tells you only about oxygenation. It provides absolutely no information about ventilation, how effectively the patient is breathing out carbon dioxide.
Ah, okay.
Someone can have a good SpO2 but be retaining CO2 dangerously.
So to get the full picture, you need an arterial blood gas.
Precisely. An arterial blood gas requires drawing blood from an artery, but it gives a wealth of vital information. Oxygenation, PaO2, SpO2, ventilation, PaO2 partial pressure of carbon dioxide, and acid-base balance, pH, bicarbonate-base deficit, plus some electrolytes. Table 60.2 in the source lists typical normal values. Interpreting these numbers is fundamental for assessing a patient's respiratory and metabolic status, especially in acute or perioperative settings.
Going back to predicting postoperative dyspnea, the source mentions using FEV1 and DLCO values to predict risk after lung resection.
Yes, predicted postoperative values are calculated based on the amount of lung tissue, specifically the number of functional bronchopulmonary segments planned for removal.
Right.
The formula basically discounts the function of the segments being removed from the preoperative values.
A predicted postoperative FEV1 of 40% is often cited as a cutoff.
It is widely cited, but the source notes that the data specifically linking that 40% figure to predicting an acceptable level of postoperative breathlessness or quality of life is limited.
So, like the decision to offer surgery even with higher risk, the predicted numbers aren't the only factor.
Correct. The source emphasizes that the clinical decision, looping back to figure 60.4, may still be to offer surgery even if the predicted risk of dyspnea is moderate or high, provided the patient fully understands and accepts the risks and the potential impact on their daily life. It's a shared decision-making process based on all the assessment data.
Are there other functional assessments besides resting PFTs, exercise testing?
Absolutely. For patients at moderate or high predicted risk of postoperative dyspnea, exercise tests provide valuable additional information about their overall cardiorespiratory reserve. These include tests like the shuttle walk test, the 6-minute walk test, or stair climbing, often with continuous oxygen saturation monitoring.
Okay.
Cardiopulmonary exercise testing, CP, is the most sophisticated form.
Do these tests have specific benchmarks for good function?
Yes, the source mentions that a shuttle walk distance greater than 400 meters or a CP value greater than 15 millikilodomin are suggested cutoffs indicating good functional capacity.
Right.
These tests assess how the heart, lungs, and muscles work together under stress, which can be a better predictor of how a patient will tolerate surgery than resting values alone.
So the assessment of fitness for major thoracic surgery is truly multi-layered. Overall health scores, cardiac evaluation, detailed resting lung function tests measuring both airflow and gas exchange, and functional exercise testing. That's a comprehensive picture the expert team built.
It absolutely is. It's about quantifying risk, understanding limitations, and ensuring the patient is fully informed about the potential outcomes before committing to a major intervention.
Let's transition now and talk about the pleura. This is the thin lining around the lungs, right?
Okay.
The source says understanding its physiology is key to much of chest surgery.
Yes, the pleura is crucial. It's a two-layered membrane. The visceral pleura covers the lung surface, and the parietal pleura lines the inside of the chest wall, diaphragm, and mediastinum.
Okay.
Normally, the space between them, the pleural space, is just a potential space, with the two layers gliding smoothly over each other during breathing.
But it contains a small amount of fluid.
A very small amount, typically only about 5-10 milliliter, acting as a thin lubricant. What's fascinating, though, is the significant turnover rate. The source notes about 1 to 2 liters of fluid are produced and reabsorbed in 24 hours. How is the space kept so dry with that much traffic?
That balance must be quite precise. The source mentions Starling forces here, similar to how fluid moves in other parts of the body.
It is a delicate balance, and figure 60.6 gives us a conceptual view. Fluid is produced from the capillaries in the parietal pleura, driven by hydrostatic pressure like a transudate. In a healthy state, the net secreting forces add up to about 11 millimole Hg.
But there's also the negative pressure created by the lung's elastic recoil, right?
Exactly. The lung naturally wants to collapse due to its elastic content, and this creates a negative pressure in the pleural space, around -4 millimole Hg. This negative pressure actually favors fluid accumulation from the parietal pleura.
So if fluid is constantly produced and the negative pressure encourages it to stay, how does the space remain mostly empty?
That's the power of reabsorption. The vast majority of the fluid, about 90%, is reabsorbed by the capillaries in the visceral pleura.
Ah, okay.
These capillaries are part of the pulmonary circulation, and they have a much higher oncotic pressure due to plasma proteins and lower hydrostatic pressure compared to the parietal pleura capillary.
The source gives numbers. Oncotic pressure around 25 millimille Hg, pulmonary capillary hydrostatic pressure around 8 millimille Hg.
Right. The net absorbing pressure driven by these visceral pleural capillaries is around 25 minus 8, which is 17 millimille Hg.
Okay.
Comparing this to the net secreting pressure of 11 mmHg from the parietal pleura, there's a net drying effect of about 6 mmHg, 1711. This constant net reabsorption is what actively pumps fluid out of the pleural space, keeping it minimal and allowing the pleural layers to stay close together, which is essential for the lungs to move freely within the chest. It's a beautiful example of physiological regulation.
It really is.
Yeah.
A hidden plumbing system working constantly to keep things just right.
What about gas in the pleural space? Normally there's none, but if air gets in, like in a pneumothorax, how does the body deal with that?
The same physiological mechanism that prevents free gas from accumulating also works to reabsorb it if it gets there. This is driven by partial pressures.
Okay.
The sum of the partial pressures of gases in the blood, oxygen, CO2, nitrogen, water vapor, is less than atmospheric pressure. This pressure gradient pulls gas from the pleural space into the blood.
So air is literally absorbed into the bloodstream and then exhaled.
Exactly. Gases move according to their solubility and concentration gradients. CO2 is very soluble and absorbs quickly. Nitrogen makes up a large portion of air, 80%, and is much less soluble, so it's absorbed slowest.
And breathing oxygen can help speed this up. Yes, giving a patient a high concentration of oxygen reduces the nitrogen content in their blood. This increases the gradient for nitrogen to move from the pleural space into the blood, accelerating its reabsorption. It's a simple but effective treatment for promoting the resolution of a small pneumothorax.
The source specifically warns about nitrous oxide anesthesia in patients with a pneumothorax.
This is a critical clinical safety point. Nitrous oxide is highly soluble in blood. If given to a patient with a pneumothorax, it rapidly moves from the blood into the pleural space, expanding the pneumothorax volume potentially very quickly and dangerously. It's a major contraindication.
Okay, so understanding that pleural physiology is key to understanding disorders like pneumothorax and pleural effusion. Let's tackle pneumothorax first.
Pneumothorax is simply the presence of air in the pleural space outside the lung. It causes the lung to collapse away from the chest wall.
Right.
It's important to differentiate this from air pockets within the lung tissue itself, although those can rupture and cause a pneumothorax.
Spontaneous pneumothorax is when it happens without obvious injury.
Yes, the source divides spontaneous pneumothorax into primary and secondary types. Primary spontaneous pneumothorax, PSP, typically affects young, thin individuals, often tall men, usually in their mid-teens to late 20s, sometimes with family history. It's caused by the rupture of small air sacs called blebs or bullae, commonly located at the top apex of the lung.
And secondary spontaneous pneumothorax, SSP.
SSP occurs in patients with underlying lung disease. Any disease that involves the pleura can cause conditions like emphysema, cystic fibrosis, or certain infections like TB. SSP tends to affect older patients and can be much less well tolerated because their underlying lung function is already compromised.
Other causes include trauma and medical procedures.
Right. Trauma, like rib fractures or penetrating injuries, is a common cause. Iatrogenic pneumothorax can happen during procedures like central line insertion, lung biopsy, or even attempts to insert a chest drain.
And then there's tension pneumothorax, which is a medical emergency.
This is critical. Tension pneumothorax occurs when air enters the pleural space but cannot escape, acting like a one-way valve. This leads to a rapid buildup of positive pressure in the hemothorax. The lung on that side collapses completely, the diaphragm is pushed down, and the entire mediastinum, the heart, great vessels, trachea, is shifted to the opposite side. This kinking and compression of the major veins returning blood to the heart critically compromises circulation, leading to shock. Recognizing and treating a tension pneumothorax is life-saving and requires immediate decompression.
What about the risk of recurrence after a pneumothorax?
The risk definitely increases after the first episode. The source notes about 1/3 of patients will have a recurrence after their first spontaneous pneumothorax.
Right.
After a second episode, roughly half will have a third. And if someone has had 3, they are very likely to have repeated recurrences. This high risk of recurrence, especially after the second episode or in certain professions, is a major driver for considering surgical intervention to prevent future episodes.
Surgical emphysema is mentioned as another disorder, air in the tissues.
Yes, surgical emphysema is air that gets trapped in the subcutaneous tissues, often felt as a crackling sensation under the skin when you press on it.
Yeah.
It happens when there's a breach in an air-containing structure that allows air to escape into the surrounding soft tissues, and some form of positive pressure pushes that air along tissue planes.
What could cause that?
The most serious cause mentioned is a ruptured esophagus that's a surgical emergency. Other causes include mediastinal emphysema associated with severe asthma or barotrauma from positive pressure ventilation, which forces air into the mediastinum and then it tracks out. It can also occur around a chest drain site if there's a persistent air leak and perhaps intermittent blockage or pressure changes in the system, allowing air to be pushed into the chest wall tissues.
So given the risk of recurrence and the potential for tension pneumothorax, when is surgery indicated for pneumothorax? Summary box 60.1 lists specific reasons.
These are the scenarios where a more definitive approach is warranted beyond just draining the air. The key indications are a second pneumothorax on the same side, a first pneumothorax on the opposite side, because bilateral pneumothorax is so dangerous, spontaneous bilateral pneumothorax, or when a pneumothorax simply failed to resolve or persists despite chest drainage.
And certain patient groups.
Yes. Patients whose profession puts them at high risk if they have a recurrence, like pilots or divers or pregnant women, often have a lower threshold for surgical management due to the potential consequences. Spontaneous hemothorax, blood in the pleural space, with pneumothorax also warrants consideration for surgery.
The British Thoracic Society guidelines from 2010 are referenced with figure 60.7 outlining the management.
The guidelines emphasize using small bore, 10 to 14 AFR chest drains, preferably inserted using the Seldenir technique, often under ultrasound guidance, as this is generally less traumatic than traditional surgical insertion. However, the source is clear. Knowing how to safely insert and manage a surgical chest drain is still a necessary skill for many medical professionals.
Let's talk about inserting and managing a chest drain then. The source calls it central to chest disease management, but potentially troublesome.
It absolutely is. It's a fundamental procedure, but needs meticulous technique to avoid complications. The safest site for insertion is the triangle of safety, illustrated in figure 60.8a.
Can you describe that?
It's on the side of the chest. Imagine a triangle bounded by the anterior edge of the latissimus dorsi muscle posteriorly, the lateral edge of the pectoralis major muscle anteriorly, and a line horizontally below the armpit.
Oh.
The nipple line, or the fifth intercostal space, typically lies within this safe area, and the fifth intercostal space is the preferred site for insertion.
What are the key steps for safe insertion, as shown in figure 60.8?
First, absolute meticulous sterility is crucial. Then, adequate local anesthesia, and this must include anesthetizing the parietal pleura, which is very sensitive. A sharp incision is made only through the skin. After that, you use blunt dissection, typically with artery forceps, to work down through the muscle layers, like the serratus anterior and intercostals.
Why blunt dissection after the skin?
To push aside muscles and tissues rather than cutting them, minimizing trauma, and the risk of bleeding or nerve damage, you should always insert the drain over the upper border of the rib.
Over the upper edge.
Yes, because the neurovascular bundle, the intercostal nerve, artery, and vein runs along the underneath edge of the rib. Going over the top edge avoids damaging these vital structures.
Got it.
The source also stresses creating an oblique tract through the tissues, so the skin incision doesn't align directly with the hole you make in the pleura. This oblique path acts like a valve, reducing the risk of air being sucked back into the chest along the drain site.
And directing the drain once it's in the pleural space.
If you're draining air, pneumothorax, the drain should be directed towards the apex of the lung as air rises. If you're draining fluid or pus, effusion and pyema, direct it towards the base of the chest as fluid collects dependently.
Securing the drain.
A retaining stitch is vital to prevent the drain from accidentally coming out. It should be secure, but not so tight that it kinks or obstructs the drain.
Okay.
The source also mentions placing a vertical mattress suture for later wound closure. This is particularly important when removing a pneumothorax drain. You want to be able to tie that suture down tightly when the drain comes out to prevent air leak through the wound. However, if you're draining an empyema where the pleural layers are likely stuck together and the tract might need to stay open for further management or drainage, you might omit the suture.
And finally, connecting it.
Immediately connect the drain to an underwater seal drainage system. This acts as a one-way valve, allowing air or fluid to escape the chest cavity, but preventing air from being drawn back in during inspiration.
Right.
The final step is always confirming the drain position and whether the objective has been achieved with a chest radiograph.
The source is quite firm about managing the drain after insertion, specifically advising against routine suction or clamping.
Yes, this is another key clinical nugget. The life-saving maneuver is the insertion of the drain to relieve pressure. not the application of suction. Suction might be used in specific situations, but routine application can be detrimental. It can pull the mediastinum off-center if the lung is slow to expand, or potentially worsen an air leak if the lung tissue is fragile. And clamping a bubbling drain is almost never appropriate and can be dangerous.
Right.
The risk of accidentally leaving a clamp on a bubbling drain and causing a tension pneumothorax is significant. While disconnecting or siphoning are theoretical risks, the source suggests they are minimal or can be managed without resorting to clamping.
So suction isn't the magic bullet, and clamping is generally dangerous. Clear guidance. What about surgical management to prevent pneumothorax recurrence? Pleurectomy or pleurodesis?
These are definitive surgical procedures performed to make the visceral pleura on the lung stick to the parietal pleura on the chest wall, preventing the lung from collapsing again if a leak occurs. They can be done via VATS or open thoracotomy.
And the goals?
The source outlines a threefold objective. First, deal with any active air leaks from the lung. Second, identify and remove or repair any blebs or bullae that were the source of the leak. And third, achieve that permanent adhesion between the pleural layers, pleurodesis.
How is that adhesion achieved?
There are a few main techniques described. Pleurectomy involves stripping away the parietal pleura from the chest wall. This creates a raw, inflamed surface that encourages the visceral pleura to fuse to it.
Okay.
Pleural abrasion uses a special instrument, almost like a surgical scourer, to scrape and roughen the parietal pleural surface, which also promotes inflammation and adhesion. Chemical pleurodesis typically involves insufflating sterile talc powder into the chest cavity. The talc causes a sterile inflammation that leads to scarring and adhesion.
Moving on to another pleural disorder, pleural effusion. This is the accumulation of excess fluid in the pleural space.
Yes, and as we discussed with the physiology, this happens when that delicate balance of fluid production and reabsorption is disturbed.
How are pleural effusions classified?
They are primarily classified based on their protein content into exudates and transudates. Exudates have a higher protein content, typically 30 GL, and are caused by inflammation, infection, or malignancy, increasing capillary permeability or blocking lymphatic drainage. Transudates have lower protein content, 30 GL, and are caused by systemic factors altering Starling forces, like increased hydrostatic pressure, XG, heart failure, or decreased oncotic pressure, XG, kidney failure. Analyzing other factors like glucose, pH, and lactate dehydrogenase further helps pinpoint the cause.
What are the common disturbances to the fluid balance that lead to an effusion?
The source lists the main mechanisms. Increased capillary hydrostatic pressure in either the parietal or visceral pleura, decreased plasma oncotic pressure, increased capillary permeability, or impaired lymphatic drainage. Understanding these mechanisms is key to understanding the underlying cause of the effusion.
Malignant pleural effusion is specifically highlighted as a common complication of cancer.
It is, and its presence is often regarded as a sign that a lung cancer is beyond surgical cure.
What causes these malignant effusions?
They can be due to direct involvement of the pleura by the primary tumor or metastases, or it can be less direct collapse of lung tissue behind a blocked airway can cause fluid. Crucially, involvement of the mediastinal lymphatics by cancer, for example from lung or breast cancer, can block the lymphatic drainage pathways responsible for reabsorbing pleural fluid, leading to an effusion even if there's no visible tumor on the pleura itself.
So a malignant effusion doesn't necessarily mean the cancer is growing on the pleura.
That's a vital distinction. While direct pleural involvement is common, obstruction of the lymphatic drainage system is another significant mechanism, and it also often indicates advanced disease.
Right.
The source also mentions malignant mesothelioma as the primary cancer of the pleura, strongly linked to asbestos exposure, which typically presents with effusion, pain, and systemic symptoms.
What's the surgeon's role in managing malignant pleural effusion?
The surgeon plays a dual role, diagnosis and palliation. Diagnosis involves obtaining a tissue sample to confirm if the effusion is malignant. Palliation involves draining the fluid to relieve breathlessness and often performing pleurodesis to prevent its reaccumulation, aiming to improve the patient's quality of life.
How are pleural biopsies obtained? Summary box 60.3 lists methods.
Options range from sending the fluid itself for cytology, looking for cancer cells but with a low yield, often missing malignancy, using a needle like an Abrams needle, also low diagnostic yield for cancer, to image-guided needle biopsy, often CT-guided, or surgical biopsy. VATS, video-assisted thoracoscopic surgery, is increasingly the preferred surgical method for obtaining tissue. It allows direct visualization, ensures complete drainage, allows targeted biopsies from suspicious areas, and enables effective talc insufflation for pleurodesis. The source notes that even with these methods, a negative biopsy doesn't completely rule out malignancy due to potential sampling error.
Let's move to pleural infection and empyema.
Empyema is the end stage of pleural infection. It's characterized by the presence of thick, infected pus in the pleural space and the formation of a thick peel or cortex of fibrin and coagulum that can trap the lung.
What's the most common cause?
The vast majority of empyemas result from the spread of infection from underlying lung tissue, typically following pneumonia or a lung abscess. But they can also be a complication of thoracic surgery, an infected traumatic hemothorax, or sometimes occur during the management of pneumothorax or other effusions. Infections below the diaphragm can also track upwards. Table 60.3 lists common causes.
The source describes the progression of empyema in phases.
Yes, when it follows pneumonia, it usually goes through 3 stages. First, the exudative phase, an initial protein-rich effusion that gets infected, often by bacteria like Streptococcus milleri. At this point, antibiotics might be sufficient, but drainage is generally preferred to hasten resolution.
Then it gets thicker.
Yes, over days, it progresses to the fibrinopurulent phase. The fluid becomes thick and pus-like, and fibrin starts to form septations, dividing the space into pockets or loculations. Drainage is definitely needed here. Antibiotics alone are unlikely to clear the thick pus.
And the final stage.
The organizing phase. This is when a thick, fibrous peel or cortex forms over the lung and the chest wall. This peel traps the lung, preventing it from expanding fully. At this stage, surgical management is often required to free the lung.
That progression sounds serious. Let's look at the surgical management of these pleural infections and effusions. VATS seems to play a big role here, too.
Absolutely. Video-assisted thoracoscopic surgery, VATS, illustrated in Figure 60.9, has transformed the surgical management of many pleural conditions. It utilizes a camera attached to a scope, displaying the image on a screen, allowing the surgeon to manipulate instruments through small ports.
What are the advantages of VATS compared to traditional open surgery?
The major benefits are avoiding a large incision and rib spreading, leading to significantly less postoperative pain and a much faster recovery time for the patient.
Right.
VATS typically requires single lung ventilation, using a double lumen endotracheal bronchial tube, so the lung on the operative side can be collapsed, giving the surgeon working space. The patient is usually positioned with the affected side up.
How is VATS used for conditions like malignant effusions?
As mentioned earlier, VATS is increasingly the go-to technique for managing undiagnosed or malignant pleural effusions. It can often be done through just 1 or 2 small ports.
Okay.
It allows the surgeon direct visual access to ensure complete drainage of the fluid, take multiple targeted biopsies from any suspicious areas on the pleura for definitive diagnosis, and then effectively insufflate talc powder throughout the pleural space for pleurodesis to prevent the fluid from returning.
And how is VATS used for empyema, especially in the fibrinopulent stage?
VATS debridement is very effective for managing loculated pleural infection in the earlier stages, particularly the fibrinopurulent phase. Using single lung ventilation and the disease side up position, the surgeon enters the pleural cavity, visualizes the pus and fibrin. They use instruments to vigorously debride and remove all the thick fluid and debris, breaking down the loculations and freeing the trapped lung to allow it to re-expand. Proper placement of chest drains for dependent drainage after the procedure is critical.
Post-procedure care after VATS debridement.
Just like after other thoracic surgery, excellent pain control, often using patient-controlled analgesia, PCA, is vital to allow the patient to take deep breaths and participate in physiotherapy.
Right.
Early and aggressive physiotherapy is crucial to help that lung re-expand fully before the chest drains are removed.
If the lung remains trapped by that thick peel in the organizing phase, the source mentions a more radical operation: decortication.
Decortication, Figure 60.10 illustrates the thickened pleura, is performed when the lung fails to re-expand after drainage of an empyema. It's a more extensive operation. The concept is to surgically remove that thick, fibrous cortex or peel that has formed over the surface of the entrapped lung and the chest wall.
And the goal is simply to allow the lung to expand again.
Precisely. By removing that restrictive layer, you free the lung, allowing it to expand fully and completely obliterate the pleural space. Obliterating the space is essential to resolving the infection and restoring lung function.
Okay.
Decortication is usually performed through a posterolateral thoracotomy incision, although VATS can sometimes be used in selected cases, typically earlier on before the peel becomes too thick and organized. It requires very careful dissection to peel off both the parietal and visceral cortex without damaging the underlying lung tissue, which is covered by the delicate visceral pleura.
That sounds like a technically demanding procedure. Let's shift gears again and talk about disorders of the airway itself.
Yeah.
Hemoptysis, coughing up blood, is a symptom that demands attention.
Absolutely. Hemoptysis is always a significant symptom requiring investigation. The source lists common causes, including lung cancer, bronchiectasis, carcinoid tumors, and various infections. While historically associated with severe mitral stenosis, that's rare now, trauma can also cause it from lung bruises or major airway injuries.
If someone has repeated episodes of hemoptysis.
The recommendation is clear, at least a chest radiograph and bronchoscopy are needed.
Right.
The source also lists associated symptoms like persistent cough, chest pain, breathlessness, hoarseness, or systemic symptoms like fatigue or weight loss. Any of these combined with hemoptysis warrant urgent investigation to identify the underlying cause.
Bronchoscopy is mentioned as a key investigative tool, with different uses outlined in Table 60.4.
Bronchoscopy allows direct visualization of the inside of the airways. There are two main types, flexible and rigid, each with distinct advantages and uses.
Let's start with flexible bronchoscopy. Figure 60.11a shows the scope, and B gives an idea of the view.
Flexible bronchoscopy is typically performed with the patient awake, under sedation, and topical anesthesia of the throat. The flexible scope is passed through the nose or mouth, past the vocal cords under direct vision.
Okay.
Its flexible tip can navigate into the smaller, segmental bronchi, making it useful for assessing the airway in cases of suspected central tumors and for obtaining tissue or sputum samples via brushings, washings, or transbronchial needle aspiration, TBNA. Its strength is maneuverability, but it provides relatively small biopsy samples, and suction is limited compared to a rigid scope.
And rigid bronchoscopy, figure 60.1a, shows that scope too.
Rigid bronchoscopy usually requires general anesthesia because you're inserting a straight, rigid tube. While less flexible than the flexible scope, it offers superior visualization of the trachea and main bronchi and is ideal for therapeutic interventions.
Therapeutic interventions.
What kind? Because it's a rigid, open tube, you can pass larger instruments or use techniques like suction very effectively. It's the tool of choice for removing inhaled foreign bodies, aspirating large volumes of blood or thick secretions that are blocking the airway, and performing intraluminal surgery, like using a laser or cryotherapy to excise or ablate obstructing tumors within the airway lumen and restore patency.
Right.
During rigid bronchoscopy, the surgeon and anesthetist share control of the airway.
The source mentions using rigid bronchoscopy to assess the operability of an endobronchial tumor.
Yes. Looking down the rigid scope, the surgeon can clearly see the tracheal rings, the carina, the split between the main bronchi and the openings of the main bronchi. They can precisely assess the location of a tumor, its extent, and particularly how close it is to the carina. This information is critical for determining if the tumor can be surgically removed while still leaving enough functional airway and lung tissue. Complications are rare, but include bleeding, pneumothorax, laryngospasm, or arrhythmias. Combining rigid bronchoscopy with techniques like laser or cryotherapy is key for managing airway obstruction due to tumors.
Besides going through the airway with a bronchoscope, what other techniques are used to get biopsies from inside the chest?
Obtaining a tissue diagnosis is crucial for confirming cancer, staging it, and planning treatment. Besides bronchoscopy, other techniques are used depending on where the lesion is located and the suspected diagnosis.
Okay.
Percutaneous needle biopsy, guided by imaging like a CT scan, is common, especially for larger, more peripheral lesions.
Yeah.
Open lung biopsy via VATS is an option if other methods fail.
EBS and EUS are mentioned in this context, especially for lymph node biopsy.
Yes, and these are fundamental tools for lung cancer staging. Endobronchial ultrasound, EBUS, shown in figure 60.14, uses an ultrasound probe on the tip of a flexible bronchoscope. This allows the physician to visualize structures outside the airway wall, particularly suspicious mediastinal lymph nodes, and precisely guide a needle, TBNA transbronchial needle aspiration, to obtain a biopsy sample. Endoscopic ultrasound, EUS, uses a similar technique, but the scope is passed down the esophagus, allowing access to mediastinal nodes that might be difficult to reach from the airway side. Getting histological proof of whether these mediastinal nodes contain cancer is vital for accurate end staging and deciding on treatment.
And navigational bronchoscopy.
Navigational bronchoscopy uses radiological imaging to create a virtual 3D map of the lung, providing GPS-like guidance during flexible bronchoscopy.
Okay.
This allows the physician to navigate the flexible scope to small lesions located in the far periphery of the lung, which are otherwise inaccessible with standard flexible bronchoscopy, to obtain biopsies, or to place markers for radiation therapy or facilitate surgical removal of small peripheral nodules.
Summary box 60.4 lists some hazards for these biopsy procedures.
Yes, certain patient conditions increase the risk. These include bleeding disorders, being on systemic anticoagulation medication, and pulmonary hypertension. These factors need to be carefully assessed and managed before performing invasive biopsy procedures.
Let's talk about airway obstruction itself, particularly in the trachea.
Tracheal obstruction is serious because it affects the main airway. It can be an acutely life-threatening emergency, causing immediate severe respiratory distress, or it can develop slowly and insidiously, with symptoms like stridor, a harsh, high-pitched breathing sound heard during inspiration, only appearing when the airway is already critically narrowed.
What are the common causes of tracheal narrowing, according to Table 60.5?
They're broadly categorized by where the cause originates. Intraluminal, something inside the airway like an inhaled foreign body or a tumor growing into the lumen. Intramural, something within the airway wall like congenital stenosis or fibrous stricture from previous intubation or infection like TB. Or extramural, something outside the airway compressing it, like a tumor in the thyroid or mediastinum or even a large aortic aneurysm.
How is tracheal obstruction treated?
Treatment depends entirely on the underlying cause. In acute emergencies, temporizing measures like intubation, if possible, or potentially urgent tracheostomy might be needed to secure the airway, although the source notes few emergency indications specifically for tracheostomy compared to other airway interventions.
Okay.
Surgical options for treating the narrowing itself can be complex, including tracheal replacement resection, where a segment of trachea is removed and the ends sewn together up to about 6 centimeters is possible. Sleeve resections of the major bronchi can also be done for central airway tumors involving the main bronchi.
Inhaled foreign bodies were mentioned as an intraluminal cause, often in children.
Yes, surprisingly common in small children. There's often an initial dramatic choking incident that seems to resolve, but the object is still lodged somewhere in the airway.
Mm-hmm.
And as we noted, due to the anatomy, they most commonly end up in the wider, more vertical right main bronchus. Surprisingly, large objects can be inhaled and cause partial disruption.
And the presentation isn't always obvious.
The source lists 3 possible presentations. Sometimes completely asymptomatic, the object is there but not causing noticeable issues. More commonly, presenting with persistent cough and wheezing due to partial obstruction, which can lead to signs of obstructive emphysema on imaging. Or presenting later with fever and productive cough if the obstruction causes a pulmonary infection behind it.
And management involves removing the object.
Exactly. Removal is necessary almost always via bronchoscopy. While flexible bronchoscopy can sometimes be used, rigid bronchoscopy is often preferred and necessary, especially for larger or impacted objects, because it provides better visualization, a stable platform, and allows the use of grasping tools and suction needed for safe removal.
Let's transition now to neoplasms of the lung, or lung cancer, which is a major focus of thoracic surgery.
Lung cancer remains one of the most common cancers worldwide. The statistics are stark. The source cites around 45,000 new cases annually in the UK, and it's the most common cause of cancer death. Overall survival rates are low, with only about 15% surviving 5 years. However, survival is heavily dependent on the stage at diagnosis.
But surgery rates are increasing.
Yes, the number of lung cancer resections performed has significantly increased, with surgery being attempted in over 30% of cases in resource-rich countries. Crucially, the patients who are candidates for surgery are typically those diagnosed in the early stages, where surgical removal offers the best chance for cure.
What's the thoracic surgeon's specific role within the lung cancer team?
The thoracic surgeon is an essential member of the multidisciplinary team. Their role encompasses diagnosis, obtaining tissue, staging, assessing spread, particularly to lymph nodes, providing palliative treatments to manage symptoms, like draining effusions or managing airway obstruction, and performing potentially curative surgical resection in appropriate cases.
And the major risk factor, overwhelmingly.
Cigarette smoking. It's responsible for 85–95% of all lung cancer cases. Lesser risk factors include atmospheric pollution and certain occupational exposures like radioactive or chromium mining.
How are lung cancers classified pathologically, particularly for treatment planning?
For practical treatment purposes, they are broadly divided into small cell lung cancer, SCLC, and non-small cell lung cancer, NSCLC. NSCLC is much more common, making up about 80% of cases.
And this distinction is important.
Very important. The source emphasizes that the pattern of disease, prognosis, and response to treatment for small cell carcinoma are distinctly different from all other types.
Right.
Because of this, SCLC is managed differently from the outset, primarily with chemotherapy, based on its histology.
Let's look at the histological types in more detail. First, small cell or oat cell carcinoma.
Small cell carcinoma is characterized by small, dense cells and is a type of neuroendocrine tumor, NET. It accounts for about 20% of lung cancers. It's aggressive and tends to metastasize early and widely, both to lymph nodes and via the bloodstream. Prognosis is poor, with median survival measured in months. While it's very responsive to chemotherapy, which can significantly improve survival, it is very rarely, if ever, cured by chemotherapy alone. Surgery is almost never an option unless the disease is discovered at a truly exceptionally limited stage.
What about the non-small cell lung cancers?
NSCLC includes several subtypes. Adenocarcinoma has now overtaken squamous cell carcinoma as the most common type of NSCLC. The source notes its increasing incidence, partly in women, potentially linked to changes in smoking patterns, like deeper inhalation of lower tar cigarettes.
Interesting.
Squamous carcinoma typically presents as a tumor in the central airways and can often appear as a cavitating lesion, a hole in the lung, on imaging. Large cell undifferentiated carcinoma is another discrete NSCLC subtype, also classified within the broader group of NETs.
The source also mentions other NETs of the lung.
Yes. This group also includes the less aggressive forms, typical and atypical carcinoid tumors. These occur in both the central airways and peripherally, about 20% are peripheral. They are typically slow-growing and notably highly vascular.
Okay.
While most behave benignly, about 15% can metastasize. Patients often present with symptoms related to airway obstruction, like recurrent pneumonia or with hemoptysis. Carcinoid syndrome, flushing, diarrhea, etc., is rare unless there are extensive metastases. The key difference from SCLC is that surgical excision is the preferred treatment for carcinoids, and the prognosis after complete removal is excellent, with over 90% 10-year survival.
That's a dramatically better prognosis. The source stresses the importance of accurate diagnosis and staging before considering surgery for lung cancer.
Absolutely vital. You need definitive proof of the type of cancer and precisely how far it has spread to determine if surgery is appropriate and offers the best chance for cure.
What are the clinical features of lung cancer? They seem to depend on the location and spread.
Yes, symptoms depend on the site of the tumor, whether it's invading surrounding structures and if it has spread. Hemoptysis, coughing up blood, occurs in less than half of patients at presentation. A persistent or changed cough is common but nonspecific.
What about pain?
Severe localized chest pain can suggest the tumor is invading the chest wall and irritating intercostal nerves. If the tumor is at the very apex of the lung, it's called a Pancoast tumor. Figure 60.2 shows an example. And it can invade the brachial plexus nerves in the neck, causing severe shoulder and arm pain, potentially leading to weakness or wasting in the hand muscles. Pancoast syndrome. Involvement of nearby sympathetic nerves can also cause Horner syndrome, drooping eyelids, small pupil on the same side.
Dyspnoea or breathlessness.
This can happen due to the tumor reducing the amount of functioning lung tissue, cancer spread into the lymphatic vessels, causing them to block up, or if a large pleural effusion develops.
And pleural fluid itself is noted as an ominous sign.
It often is. The presence of a pleural effusion typically signifies advanced disease. If there's blood in the effusion, it strongly suggests direct invasion of the pleura by the tumor.
Other signs like clubbing or HPO.
Clubbing, swelling of fingertips, and hypertrophic pulmonary osteoarthropathy, HPO, which causes painful joint swelling and periosteal changes, can occasionally occur with lung cancers. Interestingly, these can sometimes resolve after the primary tumor is surgically removed.
What if the cancer invades the structures in the mediastinum?
Invasion of mediastinal structures can cause distinct symptoms. Hoarseness can result from involvement of the recurrent laryngeal nerve, which controls the vocal cord. Difficulty swallowing dysphagia if the esophagus is compressed or invaded. Compression of the superior vena cava can lead to superior vena caval obstruction, SVCO, causing swelling of the face, neck, and upper limbs.
Small cell carcinoma is also associated with perineoplastic syndromes, right?
Yes, SCLC is known to be associated with certain perineoplastic syndromes, such as myopathies like Eden-Lambert syndrome, which causes muscle weakness similar to myasthenia gravis. These are caused by substances produced by the tumor that affect distant parts of the body.
So deciding on treatment involves thorough investigation, not just diagnosing cancer, but also accurately staging it.
Absolutely. The internationally agreed tumor node metastasis, TNM staging system, currently in its 8th edition, is the standard for assessing the extent of the disease and providing prognostic information. TERA describes the primary tumor size and extent, N describes regional lymph node involvement, and M describes distant metastases.
What stages are generally considered potentially curable with surgery?
Tumors classified as up to T3, N1, M0 are typically considered potentially curable with anatomical surgical resection and have a significantly improved prognosis when treated this way.
Right.
This is why accurate staging before surgery is so critical. You need to confirm the disease is confined to a stage where surgical removal offers a realistic chance of cure.
What about higher stages?
For more advanced stages, particularly certain stage 3 cases, a multimodality or trimodality approach is increasingly common. This might involve chemotherapy, often combined with radiotherapy, and potentially followed by surgery in carefully selected fit patients.
So treatment isn't just surgery or not surgery?
Not at all. Treatment planning is complex and involves the entire multidisciplinary team considering the cancer stage, the histological type, SCLC versus NSCLC, and non-tumor factors like the patient's overall general fitness and lung function.
Okay.
If the disease is incurable, the focus shifts entirely to palliative treatments to manage symptoms and maximize quality of life.
Survival rates are generally low, but what factors most influence the prognosis?
The source lists the key factors: the size and extent of the primary tumor, T status, the overall stage of the disease as determined by the full TNM classification, the histological type, especially SCLC versus NSCLC, and the general condition and health of the patient. Early detection and surgical resection in appropriate patients remain the best hope for cure.
Let's delve into the specific investigations used for the diagnosis and staging of lung cancer. The source notes increasing emphasis on early detection.
Yes, efforts are focused on diagnosing cancer at an earlier, more curable stage. There are guidelines on specific symptoms and signs that should prompt an urgent chest X-ray and referral to a lung cancer specialist team.
Starting with non-invasive investigations. Chest radiography, X-ray.
A standard chest X-ray is often the first test and can detect most lung cancers. However, it has limitations. Smaller or early-stage tumors can be hidden by other structures.
Right.
What might be visible are secondary effects of the tumor, like a pleural effusion, collapse of lung tissue behind an obstructed airway, or a raised diaphragm. Figure 60.2, illustrating a Pancoast tumor, shows how these subtle findings can be present.
Computed tomography, CT scan is the next step.
A CT scan is the standard first-line imaging investigation if lung cancer is suspected based on symptoms or X-ray. It provides much greater detail. For the surgeon, it's vital for assessing the T stage, the resectability of the primary tumor, and the N stage involvement of lymph nodes. The source gives helpful rules of thumb regarding lymph node size. Nodes over 2 centimeters are likely involved in about 70% of cases, while those under 10 millimeters are unlikely to be. CT also allows imaging of other organs to check for distant metastases, M stage, in places like the liver or adrenal glands. Figure 60.13 shows an example of enlarged paratracheal lymph nodes on a CT.
Positron emission tomography, PET scan, is also widely used.
PE scanning, often combined with CT, PET-CT, uses a radioactive tracer called fluorodeoxyglucose, FDG. Cancer cells have a high metabolic rate and take up FDG much more avidly than most normal tissues, causing it to accumulate and light up on the scan.
Okay.
This is useful for identifying potential tumors and detecting metastases in lymph nodes or distant organs. However, it's crucial to remember that infection, inflammation, or reactive lymphadenopathy can also be FDG avid, so PE findings must be interpreted carefully in context with other information.
Sputum cytology is sometimes used.
Examining sputum under a microscope for malignant cells can occasionally help diagnose cancer, but it has a high false negative rate, meaning it misses many cancers that are present. So it's not a definitive test if negative.
To get definitive diagnosis and more accurate staging, invasive investigations are often necessary.
Yes, once lung cancer is suspected, invasive procedures are used to obtain tissue samples. The choice of procedure depends on the location of the suspected tumor, central or peripheral, and the clinical staging. For example, if enlarged lymph nodes are seen on imaging.
Flexible bronchoscopy comes up again here for diagnosis.
Right. As we discussed, flexible bronchoscopy under sedation is the standard procedure for assessing and obtaining samples from tumors located in the central airways. It allows visual assessment, obtaining brushings and washings for cytology, and performing TBNA, transbronchial needle aspiration, of tissue or nodes visible from the airway wall.
EBS and EUS are particularly important for lymph node biopsy and staging.
Absolutely critical. Endobronchial ultrasound, EBUS, as shown in figure 60.14, uses ultrasound on the bronchoscope tip to visualize mediastinal lymph nodes adjacent to the airways, allowing precise needle aspiration, TBNA, for biopsy.
Wow.
Endoscopic ultrasound, EUS, uses a similar technique via the esophagus to access mediastinal nodes less reachable by bronchoscopy. Obtaining histological proof of whether these mediastinal nodes contain cancer is paramount for accurate end staging and deciding on whether surgery is an option or if other treatments are needed. This is the kind of detailed staging information that informs expert decision-making.
Navigational bronchoscopy helps reach peripheral lesions.
Correct. Using radiological guidance and a 3D map, navigational bronchoscopy extends the reach of flexible bronchoscopy to biopsy smaller lesions located in the outer parts of the lung, which are difficult to access with standard flexible scopes. It can also be used to place markers.
CT-guided biopsy is another option for peripheral lesions.
Yes, percutaneous needle biopsy guided by CT scan is commonly used for more peripheral lesions, especially if they are large enough and accessible from the chest wall. It can provide cells for cytology or a core tissue sample for histology. A known hazard is pneumothorax, occurring in about 10% of cases, though often small and not requiring a drain. It's generally contraindicated in patients with very poor respiratory reserve, where even a small pneumothorax could be dangerous.
Finally, surgical diagnosis and staging procedures.
Sometimes surgical procedures are needed to obtain a definitive tissue diagnosis, especially if non-surgical methods have been inconclusive, or to definitively stage the mediastinal lymph nodes. Getting histological proof of the status of mediastinal nodes is crucial for avoiding unnecessary major surgery in cases that are too advanced for cure, or conversely, not denying surgery to a patient whose enlarged nodes were benign. Mediastinoscopy is a standard procedure for this.
Mediastinoscopy, figure 60.15, shows the approach.
Mediastinoscopy involves a small incision at the base of the neck. Through careful blunt dissection in front of the trachea, a scope, the mediastinoscope, is advanced, allowing visualization and biopsy of important mediastinal lymph node stations, particularly the peritracheal and subcarinal nodes.
Okay.
It's a fundamental technique for accurate staging of the mediastinum in lung cancer, and also used for diagnosing other mediastinal conditions like lymphoma or sarcoidosis.
And VATS can also be used for diagnosis and staging.
Yes, video-assisted thoracoscopic surgery allows direct visualization and biopsy of lung lesions or mediastinal lymph nodes that might be difficult to access otherwise, or when previous biopsies were inconclusive. It provides an opportunity to obtain a diagnosis, stage the mediastinum, and get a good assessment of the likely resectability of the tumor.
So a whole arsenal of investigations, from basic imaging to advanced surgical biopsy, is used to get the precise diagnosis and staging that dictates treatment for lung cancer. Let's move now to the surgical approach itself. How was lung cancer resected? Thoracotomy is the traditional method.
Thoracotomy remains a standard approach, although less invasive techniques are increasingly used. The most frequent indication is lung cancer resection. Trauma surgeons also need to be skilled in performing emergency thoracotomy.
The standard approach is posterolateral thoracotomy.
Yes. This approach from the back and side provides excellent access to the lung, the major bronchi, the pleura, the thoracic aorta, the esophagus, and the posterior mediastinum on that side of the chest.
The source mentions the use of a double-lumen endotracheal tube. Figure 60.16 illustrates this.
This is absolutely essential for most major thoracic surgeries, including lung resection. A double lumen tube has two separate channels, allowing the anesthetist to independently ventilate each lung.
Right.
During surgery, they can ventilate the non-operative lung while intentionally collapsing the lung on the side where the surgeon is working. This provides the surgeon with a clear, static field of view for dissection, significantly improving safety and precision, and also helps protect the dependent, non-operated lung. Figure 60.17 shows the typical lateral patient positioning for this approach.
The incision is below the scapula.
Yes, typically 1 to 2 centimeter below the tip of the shoulder blade, curving upwards and backwards between the scapula and the spine. The incision goes through the skin and subcutaneous tissue, then the latissimus dorsi muscle is divided. A plane is developed manually beneath the scapula and serratus anterior muscles.
And then you get to the ribs. Figure 60.18 helps visualize the layers and approach to entering the chest.
You count the ribs, usually from the second palpable one. The chest cavity is entered by either scoring the periosteum of a rib, like the 6th or 7th, near its upper border and peeling it away, or by cutting through the intercostal muscles just above the rib. Again, emphasizing cutting above the rib is crucial to avoid the neurovascular bundle running along the lower edge. Once the pleura is exposed, it's carefully entered, and a rib spreader is inserted gently to create working space without fracturing the ribs.
The source also describes an emergency thoracotomy specifically for trauma.
Yes, in critical, life-threatening situations resulting from penetrating chest trauma, an emergency room thoracotomy may be performed. This is a rapid anterior approach, typically on the left side. Left anterior thoracotomy, figure 60.19.
Okay.
It provides quick access to the left pleural cavity to control massive bleeding from the lung or vessels, and crucially, to the pericardium surrounding the heart to address cardiac tamponade, blood compressing the heart. It can be extended across the sternum to a bilateral clamshell incision if needed for better access. No specialized equipment is needed, just the scalpel and scissors, highlighting its emergency nature.
Postoperative pain management is highlighted as extremely important after thoracotomy.
It's not just important, it's critical for recovery. Effective pain control is essential because patients need to be able to take deep breaths, cough effectively to clear secretions, and mobilize early.
Right.
If pain restricts breathing and coughing, they are at high risk of complications like pneumonia and poor gas exchange.
What strategies are used?
The source lists several strategies, often used in combination, to provide robust pain control. These include placing regional catheters like epidural, paravertebral, or extrapleural catheters to deliver local anesthetic that blocks the nerve supplying the chest wall. Intercostal nerve blocks can also be performed during surgery with long-acting local anesthetics. Patient-controlled analgesia, PCA, where the patient can give themselves small intravenous opioid doses on demand, is common. And background oral analgesia like paracetamol and NSAIDs are also used.
And minimizing long-term pain.
Long-term chronic pain after thoracotomy can be a problem. The source notes that this can be reduced by careful surgical technique during the initial operation, particularly avoiding rib fractures and ensuring that the intercostal nerves are not trapped or irritated when closing the wound.
We discussed VATS for pleural procedures. It's also used for lung resection now.
Yes, video-assisted thoracoscopic surgery, VATS, is increasingly the preferred approach for early-stage lung resections in many centers. It offers a less invasive way to perform procedures like lobectomy or segmentectomy.
How is it done for resection?
Using small incisions, ports, often just 1, uniportal, 2, or 3, VATS allows the surgeon to dissect the hilar structures, the pulmonary artery, veins, and bronchus, divide the lung tissue along the fissure, and perform a full lymph node staging dissection, just as they would in an open operation. It still requires single lung ventilation.
And the advantages compared to open thoracotomy for resection?
The key benefits are avoiding the large incision and rib spreading, leading to significantly less postoperative pain, a shorter hospital length of stay, and a speedier overall recovery, which is particularly beneficial for frail or elderly patients.
Robotically assisted thoracic surgery, RATS, is mentioned as the newest technological approach. Figure 60.20 shows the setup.
RATS utilizes a robotic system to perform thoracoscopic surgery. The surgeon sits at a console, often in the same room, viewing a 3D image of the operative field and manipulating robotic arms that are inserted through small incisions in the patient's chest.
What are the potential benefits of RATS?
Similar to standard VATS, it offers less pain, reduced blood loss, and potentially a shorter recovery time compared to open surgery.
Okay.
For the surgeon, the robotic system provides advantages like enhanced 3D vision and greater dexterity and range of motion with the instruments compared to traditional VATS tools.
And where might RIs be particularly useful?
The increased precision and maneuverability can be particularly advantageous for more technically challenging procedures, such as complex segmentectomies or the dissection required for mediastinal tumors like thymectomy.
So, surgical approaches are constantly evolving towards less invasive techniques where appropriate leveraging technology while traditional open methods remain essential for many cases. Let's get into the specific surgical management of lung cancer, the different types of resections performed.
The core principle guiding surgical resection for lung cancer is to remove all the identifiable cancer, including the primary tumor and any involved regional lymph nodes, while preserving as much healthy, functional lung tissue as possible. Patient selection is paramount and based on both the stage of the cancer and the patient's physiological fitness.
Surgery with curative intent is typically offered for early-stage disease. Table 60.6 outlines some recommendations, like those from NICE.
Yes, according to recommendations like those from NICE, surgery is typically offered to patients with early-stage non-small cell lung cancer, classified as T1 to T3, N0 to N1, M0, meaning the tumor is confined to the lung and perhaps nearby lymph nodes, but has not spread to distant sites. Lobectomy, removal of a single lobe via open or thoracoscopic approach, is the standard treatment of choice for these stages.
What if the tumor is very small or the patient's lung function is borderline?
For smaller tumors, say 1 to 2 centimeters, particularly certain subtypes like predominantly ground glass or lipidic pattern adenocarcinomas, and in patients with borderline lung function who might not tolerate a full lobectomy, lung-sparing resections like segmentectomy or wedge resection may be considered. These procedures are also combined with removal of the regional lymph nodes.
Can you clarify the difference between segmentectomy and wedge resection?
Segmentectomy is an anatomical resection. As we discussed earlier, it involves carefully dissecting and tying off the specific pulmonary artery, vein, and bronchus, supplying a single bronchopulmonary segment, removing just that segment while preserving the rest of the lobe.
Right.
A wedge resection, on the other hand, is a non-anatomical excision. It's simply cutting out a wedge of lung tissue that includes the tumor without specifically isolating the segmental vessels or bronchus. Both are increasingly performed via VATS or RATS.
Lobectomy is still the standard for many early-stage cancers.
It is. Lobectomy involves removing an entire lobe of the lung. It requires dissecting along the fissure, separating the lobes, and meticulously isolating and ligating the branches of the pulmonary artery and veins, and the bronchus supplying that specific lobe. The bronchus is typically sealed closed with a surgical stapler, although it can be sewn.
What's the expected recovery like after a lobectomy?
Postoperatively, patients generally do not require routine admission to the intensive care unit and ideally avoid postoperative ventilation. The 30-day mortality rate for lobectomy is relatively low, typically 1–2%.
Okay.
Common morbidities like chest infection or cardiac arrhythmias occur in about 10% of patients. The average hospital stay is usually around 5–7 days.
Pneumonectomy is the removal of an entire lung.
Yes, this is a significantly larger operation with a higher mortality rate, typically 5–8%. The number of pneumonectomies performed has decreased over time and now accounts for less than 5% of lung cancer surgeries in the UK. It is reserved for centrally located tumors involving the main bronchus or those that straddle the fissure in a way that cannot be adequately removed by lobectomy. The surgeon must be very confident based on the preoperative assessment that the patient has sufficient lung function and overall fitness to tolerate living with only one lung.
Bronchoplastic or sleeve resections are mentioned as a way to avoid pneumonectomy.
This is an increasingly important technique, particularly with the desire to preserve lung tissue and reduce the morbidity and mortality associated with pneumonectomy. A sleeve resection involves removing a segment of a major airway, like the main bronchus, that is invaded by a tumor, along with the lung lobe supplied by that airway. Then, the cut end of the remaining major airway is reconnected, reanastomosed, to the lobe or bronchus of the preserved lung tissue. It's a more complex operation, but allows removal of a centrally located tumor while avoiding the removal of an entire lung.
Table 60.6 also mentions surgery for T3 NSCLC involving the chest wall.
Yes, if a lung tumor has directly grown into the chest wall, classified as T3, complete surgical resection is still the aim. This requires removing the involved portion of the chest wall, either just the pleura, extrapleural, or a full block of ribs and muscle, along with the lung resection to achieve clear margins.
And for certain stage SEA disease, specifically N2 involvement.
For selected patients with operable stage IIIA NSCLC, with N2 nodal involvement, cancer in mediastinal lymph nodes on the same side, who are fit for intensive treatment, a multimodality approach is often considered. According to NICE recommendations, Table 60.6, this may involve chemotherapy, potentially followed by radiotherapy, and then surgery. This is a complex area discussed by the multidisciplinary team.
The detailed assessment of fitness for curative intent treatment is further outlined in Table 60.7.
Table 60.7 provides specific criteria and thresholds used in fitness assessment based on recommendations like those from NICE. It lists factors like FEV1 and TLCO, transfer factor, or DLCO, corrected for hemoglobin, cutoffs for considering surgery, exercise test benchmarks like shuttle walk distance, 400 meters, and CPET values, 15 millikilojoules, the use of global risk scores like thoracotomy, and the steps for cardiac assessment, including the timing after an MI and cardiology referral for higher risk patients. It reinforces that while these numbers are guides, the ultimate decision can still be to offer surgery even with suboptimal lung function if the patient understands and accepts the risks of potential postoperative breathlessness.
So, lung function tests not only help predict dyspnoea, but also influence the surgeon's choice of resection type.
Absolutely. The results of PFTs, especially the predicted postoperative values and exercise test capacity, help the surgeon determine if the patient can tolerate a segmentectomy, a lobectomy, or only potentially a pneumonectomy, or if any type of lung resection carries too high a risk.
Let's talk about complications that can occur after lung resection. Bleeding seems like an obvious risk.
Yes, bleeding is a potential complication, although careful surgical technique minimizes the risk from divided vessels. However, it can be severe if there are dense adhesions from previous infections or surgery that obscure anatomy and make dissection difficult.
Respiratory infection is common postoperatively.
This is particularly prevalent in patients who are current or former smokers, which is common in lung cancer patients. They are prone to developing areas of collapsed lung tissue, basal collapse, and low blood oxygen levels, hypoxemia after surgery, which significantly increases their risk of chest infection.
What about persistent air leak after surgery?
Chest drains are routinely placed during surgery to remove air and fluid from the chest cavity and detect air leaks from the lung surface where tissue has been cut or stapled. Sometimes an air leak persists postoperatively, preventing the remaining lung from fully expanding to seal the leak.
Okay.
If it's prolonged and doesn't settle with conservative management, rethoracotomy may be necessary to find and surgically seal the source of the leak.
Bronchopleural fistula is mentioned as a particularly serious complication.
This is indeed a very serious complication associated with high morbidity and mortality, particularly after a pneumonectomy, removal of an entire lung. After a pneumonectomy, the space where the lung used to be initially contains air, which gradually gets absorbed and fills with fluid over time. Figure 60.21 shows chest x-rays illustrating this process and how a rising fluid level is monitored. A bronchopleural fistula occurs if the bronchial stump, the end of the main airway that was sewn or stapled closed, breaks down or dehisces.
What are the consequences of that breakdown?
If the stump breaks down, it creates an abnormal connection between the airway and the empty space, which is now filling with fluid that almost inevitably becomes infected. This infected fluid can then spill back into the remaining healthy lung, and the patient often coughs up large quantities of this fluid. It is a life-threatening situation that requires highly specialized management. Patients are nursed sitting up with the affected side dependent to try and prevent fluid from entering the remaining lung. A pleural drain is needed, connected to an underwater seal, and importantly, not suction, which could worsen the leak. These fistulae are very unlikely to heal on their own.
That sounds incredibly challenging to manage. What about overall postoperative care after thoracic surgery? The source mentions enhanced recovery after surgery, or EOS.
EOS is a modern evidence-based strategy aimed at reducing the physiological stress response caused by surgery, minimizing complications, reducing the length of hospital stay, and speeding up the patient's return to their baseline level of function. Its principles are increasingly applied to thoracic surgery, including lung cancer resection.
What are the key aspects of postoperative management?
Patients undergoing lung resection often have limited respiratory reserve, so proactive management to prevent complications is key. Avoiding infection is crucial, as is avoiding fluid overload, which can compromise lung function.
Right.
Chest drains are monitored and removed as soon as air leaks settle and drainage volume is minimal. Early mobilization, getting the patient up and moving as soon as possible, along with breathing exercises and regular physiotherapy, started often on the first postoperative day, are fundamental.
And effective pain management is crucial for this early recovery.
Absolutely vital. Effective pain control is paramount because it allows the patient to take deep breaths, participate in coughing to clear secretions, and engage in physiotherapy. These actions are necessary to ensure normal breathing patterns and adequate gas exchange are restored early in the recovery period.
What are the strategies used for managing postoperative pain?
As we mentioned earlier with thoracotomy, multiple strategies are typically used in combination. These include regional anesthetic techniques like a paravertebral, extrapleural, or epidural catheter, which deliver local anesthetic directly near the nerve supplying the chest wall. Intercostal nerve blocks performed during surgery with long-acting agents are also used. Patient-controlled analgesia, PCA, allows the patient to administer small IV opioid doses for breakthrough pain. And background oral analgesia, like paracetamol and NSAIDs, are also part of the regimen.
And reducing the risk of long-term pain.
Chronic pain after thoracic surgery can occur. The source notes that the risk of long-term pain can be reduced by meticulous surgical technique during the initial operation, specifically avoiding rib fractures and ensuring intercostal nerves are not entrapped or irritated during the process of closing the wound.
Beyond primary lung cancer, surgery is sometimes considered for lung metastases cancer that is spread to the lungs from elsewhere in the body.
Yes. The lung is unfortunately the most common site for metastases for many other types of solid cancers, usually via hematogenous bloodstream spread. The presence of lung metastases is generally a sign of advanced systemic disease, and overall curative options are few. However, surgical resection of lung metastases, known as metastasectomy, may result in a survival advantage in carefully selected patients, particularly those with metastases from primary tumors like colorectal cancer, although the evidence is still somewhat uncertain and often based on retrospective series.
What are the key criteria for selecting patients for metastasectomy?
Strict selection criteria are applied. Key factors include that the primary tumor must be controlled or successfully treated. There should be no evidence of metastases anywhere else in the body outside the chest. It must be possible to completely resect all visible lung metastases using lung-sparing techniques. And the patient must have acceptable operative risks and sufficient pulmonary function remaining after the planned resection.
What surgical approaches are used for metastasectomy?
VATS, video-assisted thoracoscopic surgery, is increasingly favored over open thoracotomy due to its advantages of reduced pain, shorter hospital stay, and speedier recovery, which is important as these patients may require further treatments or surgeries in the future.
Okay.
However, the source highlights a disadvantage of VATS for metastasectomy. The surgeon cannot manually palpate or feel the entire lung surface, potentially missing small, deeper nodules that were not visible on preoperative CT scans. With an open thoracotomy, the surgeon can systematically feel the entire lung to identify all palpable nodules.
And the principle of resection using lung-sparing techniques.
This is a very important principle for metastasectomy. The aim is to use wedge resections or segmentectomies rather than lobectomy whenever possible.
Right.
This is because these patients may develop new metastases in the future and might require repeat surgeries. Preserving as much healthy lung function as possible at each operation is critical to allow for potential future interventions and maintain quality of life.
And the long-term outcome after metastasectomy.
This depends significantly on the type of primary tumor. The source notes that metastasectomy for germ cell tumors tends to have the best outcomes. For epithelial tumors, carcinomas like colorectal cancer, retrospective series report 5-year survival rates in the range of 30–40% after complete metastasectomy.
What about benign lung tumors? They're less common than malignant ones.
Yes, benign lung tumors are relatively uncommon, accounting for less than 15% of solitary nodules found incidentally on chest x-rays.
How do they typically present?
Presentation depends on location. If they are peripheral, out in the lung tissue, they usually cause no symptoms until they grow quite large, maybe compress something. If they are central, near the major bronchi, even when small, they can cause symptoms like hemoptysis, coughing up blood, or signs of bronchial obstruction.
Are there features that suggest a nodule is likely benign?
Features on a chest x-ray that suggest a nodule is likely benign include if it has not increased in size over a period of more than 2 years, or if it shows certain patterns of calcification. However, despite these signs, a tissue diagnosis is usually pursued to be certain, especially if there's any doubt or suspicion, particularly in a smoker.
What are the most common types of benign nodules or tumors?
The most common type of benign nodule seen incidentally is a granuloma, often the remnant of an old infection like tuberculosis or histoplasmosis. The most common benign tumor is a hamartoma, which is considered a developmental abnormality composed of a mixture of different tissues like cartilage and fat. Diagnosis and definitive treatment for most benign tumors involve surgical excision. Other less common benign tumors can arise from mesenchymal elements like cartilage, fat, or muscle. Deposits of amyloid can also appear as a nodule on imaging, sometimes called a pseudotumor.
Let's shift our focus now to the mediastinum.
The mediastinum is the central compartment of the chest. It's the space bounded by the sternum in front, the vertebral column behind, the diaphragm below, and the pleural surfaces on either side. It extends from the thoracic inlet at the base of the neck down to the diaphragm.
What critical structures are located within the mediastinum?
This central space houses vital organs and structures including the heart and the great vessels, the aorta, pulmonary arteries, superior and inferior vena cavae, the trachea and the main bronchi, and the esophagus. It also contains important regional lymph node chains that drain the organs of the chest. Figure 60.22 shows the arbitrary but clinically useful subdivisions of the mediastinum into superior, anterior, middle, and posterior compartments, which helps in localizing masses or pathology.
The surgical approach to masses or tumors in the mediastinum depends on their location.
Exactly. As illustrated conceptually in Figure 60.22, tumors in the anterior mediastinum are often approached through a median sternotomy, cutting through the breastbone down the middle, or increasingly using RAs, robotically assisted thoracic surgery, particularly for thymomas.
Right.
Posterior mediastinal masses are typically accessed via thoracotomy or VATS. Superior mediastinal lesions might require incisions in the neck, transcervical. Middle mediastinal masses are often approached via thoracotomy or VATS, depending on their exact position and relationship to vital structures.
What are the usual primary tumors that originate within the mediastinum?
The source lists the most common types: thymomas arising from the thymus gland, neurogenic tumors arising from nerves, germ cell tumors, and lymphoma. While metastatic disease to mediastinal lymph nodes is far more common, these are the primary tumors of this space.
Thymoma is mentioned as the most common primary mediastinal tumor. Figure 60.23 shows one on CT.
Yes, thymomas account for about 25% of mediastinal tumors and arise from the epithelial cells of the thymus gland, which is located in the anterior mediastinum. They vary in their biological behavior from benign and non-invasive to aggressive and invasive.
Okay.
They are staged using systems like the Musawaka classification or, increasingly, the TNM system. Thymomas have a high association with myasthenia gravis, a neuromuscular disorder. Interestingly, removing the thymus, thymectomy, can sometimes improve symptoms of myasthenia gravis even if a distinct thymoma isn't present, which is why thymectomy is sometimes performed for this condition alone.
How is malignancy assessed for a thymoma?
The most reliable indicator of malignancy for a thymoma mentioned is invasion through the capsule surrounding the tumor. Diagnosis and treatment involve complete surgical removal of the thymus, thymectomy,
Right.
for larger tumors, over 5 centimeters, or when there's suspicion of invasion, a median sternotomy provides excellent access. For smaller thymomas, or when performing thymectomy for myasthenia gravis alone, less invasive approaches like VATS or a transcervical approach, sometimes combined with VATS, can be used.
Germ cell tumors are another type found here.
The anterior mediastinum is the most common site outside of the gonads for germ cell tumors to develop, accounting for about 13% of mediastinal masses or cysts. These tumors contain elements derived from all 3 embryonic cell layers and typically present in young adults. About 75% of these are benign and cystic, like dermoid cysts, but even benign masses can cause compression of nearby structures and are best excised. Malignancy is suspected if serum markers like alpha-fetoprotein, HCG, or CEA are elevated. Management for malignant germ cell tumors usually involves chemotherapy first. Surgery may then be considered for any residual mass seen on CT, particularly if the tumor markers have normalized after chemotherapy. If markers remain elevated, further chemotherapy is usually given.
Lymphoma is also a frequent cause of a mediastinal mass.
Yes, lymphoma, a cancer of the lymphatic system, is a common finding in the mediastinum, particularly in the anterior compartment. It can cause symptoms like superior vena cava obstruction or compression of the trachea or bronchi. The main treatment for lymphoma is typically chemotherapy. Surgery is rarely needed, usually only to obtain a tissue biopsy for definitive diagnosis if it can't be obtained through less invasive means. Mesenchymal
tumors and ectopic thyroid tissue can also be found in the mediastinum.
Tumors arising from connective tissues can occur. Lipomas, fatty tumors, are relatively common in the anterior mediastinum, but other mesenchymal tumors are rare.
Okay.
Ectopic thyroid tissue located in an abnormal place, or the extension of a goiter from the neck down into the chest, a retrosternal goiter, can present as a mediastinal mass. Excision is usually required if they cause symptoms like airway compression or stridor, typically approached via a neck incision, but sometimes requiring a median sternotomy for access to the chest portion.
Neurogenic tumors are more prevalent in the posterior mediastinum. Figure 60.24 shows one on CT.
Neurogenic tumors arise from the sympathetic nervous system or peripheral nerves and are more commonly found in the posterior mediastinum. They can be incidental findings or cause symptoms if they grow large or compress nerves, potentially causing pain. Examples include neuroblastoma in children and schwannomas or neurofibromas in adults, which are usually benign. A pheochromocytoma, a rare tumor arising from the sympathetic chain, can produce hormones and cause an endocrine syndrome. Excision is generally recommended for neurogenic tumors, especially if they are symptomatic or their nature is uncertain. They are often approached via thoracotomy or VATS for smaller tumors. Figure 60.25 shows a VATS view.
And enlarged mediastinal lymph nodes.
Enlarged mediastinal lymph nodes are a very common finding and are frequently involved by metastatic cancer from elsewhere, sometimes mimicking a primary mediastinal mass. Symptoms are typically due to compression or invasion of surrounding structures.
Okay.
As discussed earlier with lung cancer staging, surgical procedures like mediastinoscopy are often used for diagnosis to obtain tissue from these nodes, but resection of the nodes themselves as a treatment for metastatic disease is usually not the primary approach.
Besides primary tumors, the mediastinum can also contain cysts.
Yes, while some primary tumors can be cystic, the mediastinum is also a common site for other types of cysts, many of which are embryological remnants. The source mentions thymic cysts, pericardial cysts near the heart, bronchogenic cysts arising from the developing airway, and foregut cysts arising from the developing digestive tract. Figure 60.26 shows a bronchogenic cyst splaying the carina.
How do these cysts typically present?
They can be completely asymptomatic and discovered incidentally on imaging, or they can cause symptoms due to local compression on nearby structures like the trachea, bronchi, or esophagus if they grow large.
And the management.
Surgical excision is generally recommended for mediastinal cysts, either if the exact diagnosis is unclear based on imaging and there's any suspicion of malignancy, though rare for most cysts, or if the patient is experiencing symptoms due to compression.
Let's briefly touch on some other medical conditions affecting the chest for which surgery might be required. Bronchiectasis is mentioned.
Bronchiectasis is a condition characterized by chronic, irreversible dilatation of the medium-sized bronchi, often the end result of severe or recurrent infection or airway obstruction. If the bronchiectasis is widespread throughout the lungs, surgery is almost never an option. However, if the disease is strictly localized to one specific part of the lung, surgical removal of that bronchiectatic segment or lobe can be an effective treatment for specific problems like recurrent severe infections confined to that area or significant localized hemoptysis, coughing up blood, originating from the abnormal airways.
Lung abscesses. Table 60.8 lists various causes.
A lung abscess is a localized collection of pus within the lung tissue, typically appearing as a cavity with a fluid level on a chest x-ray, or sometimes containing a fungal ball called a mycetoma. While most acute lung abscesses can be successfully managed with prolonged courses of antibiotics and postural drainage, surgery is generally avoided due to the risk of spreading infection. In some cases, small drains can be placed into the abscess cavity under radiological guidance, often in an intensive care setting, to help drainage. Causes are varied, including specific types of pneumonia, bronchial obstruction, chronic respiratory sepsis, or even spread from infections elsewhere. Table 60.8.
Tuberculosis is a classic lung disease. Is surgery still needed for TB?
In resource-rich countries with effective chemotherapy, surgery for tuberculosis is now rarely indicated. If surgery is performed, it is absolutely essential that it is combined with and covered by an adequate course of anti-TB chemotherapy. Surgery alone will not eradicate the infection.
What are the specific indications for surgery in TB, according to Summary Box 60.5?
Indications are limited and include a suspicious lesion seen on imaging that cannot be definitively excluded as cancer despite other tests, a chronic tuberculous abscess or cavity that has not responded to chemotherapy, the presence of an aspergilloma, a fungal ball within a pre-existing TB cavity, or severe life-threatening hemoptysis originating from a TB cavity or an aspergilloma within it.
Right.
Sometimes surgical procedures like obtaining a tissue biopsy are necessary just to establish the diagnosis if TB is strongly suspected clinically, but cultures from sputum or pus are negative.
Pulmonary sequestration is another condition mentioned.
Pulmonary sequestration is a congenital abnormality where a section of lung tissue is essentially non-functional. It's separated from the normal bronchial tree, lacks a proper connection to the airways, and often has other developmental abnormalities, particularly receiving its arterial blood supply directly from the aorta systemic circulation instead of the pulmonary artery. This tissue frequently becomes cystic or infected over time.
Are there different types?
Yes, there are two main types. Interlobar sequestration occurs within the normal lung tissue and often causes symptoms like recurrent infection or hemoptysis because it can sometimes connect to the normal airway system.
Okay.
Extralobar sequestration is outside the normal lung, usually between the lung and the chest wall or diaphragm. It's typically asymptomatic as it lacks air spaces and is often found incidentally.
Lung cysts.
Lung cysts can be developmental or acquired. Developmental cysts tend to become infected. Acquired cysts can contain air or fluid and can be single or multiple. Pulmonary hydatid disease, caused by a parasite, can cause large cysts in the lungs in endemic areas. Air cysts, known as bullae, figure 60.27 shows a bulla on VTS, can occur spontaneously or as part of emphysematous degeneration in conditions like COPD. Very large bullae might require surgery to prevent rupture, causing pneumothorax, or to improve function by removing space-occupying lesions that compress surrounding healthy lung.
Lung transplantation is mentioned as a treatment for end-stage lung disease.
Yes, lung transplantation is an established and life-saving therapy for carefully selected patients with severe, irreversible end-stage parenchymal lung diseases like COPD, cystic fibrosis, or pulmonary fibrosis, or certain pulmonary vascular diseases. However, its availability is significantly limited by the shortage of suitable donor lungs.
Switching gears one last time to chest trauma. This is a significant area of surgical management.
Chest trauma is responsible for a large proportion of deaths from road traffic accidents, over 70%. A methodical and exact approach is essential, following principles like those outlined in ATLS, Advanced Trauma Life Support, because signs of significant chest injury can be easily missed, especially when other severe injuries are present. The mortality rate for isolated blunt chest trauma is around 10%, but jumps to around 30% if other major injuries exist. Penetrating trauma, mortality varies greatly from about 3% for a simple stab wound to around 15% for gunshot wound.
When is emergency room thoracotomy indicated for trauma?
Emergency room thoracotomy, opening the chest in the emergency department, is a procedure performed in extremis for specific indications in severely injured patients. For blunt chest trauma, indications include signs of massive hemothorax, suspected cardiac tamponade, or witness cardiac arrest in the resuscitation area. Success rates for this in blunt trauma are unfortunately low. Indications are similar for penetrating trauma.
And the approach for emergency thoracotomy?
The standard is a rapid left anterior thoracotomy, typically through the fourth or fifth intercostal space. Figure 60.19. It doesn't require specialized surgical instruments. A scalpel and scissors are sufficient.
Right.
This provides immediate access to the left pleural cavity to deal with massive bleeding and, crucially, to the pericardium surrounding the heart to address cardiac tamponade or perform open cardiac massage. This approach can be extended across the sternum to a bilateral clamshell incision if needed.
Let's talk about the diaphragm, the muscle separating the chest and abdomen.
The diaphragm is a vital fibromuscular structure that plays a central role in breathing by increasing the vertical dimension of the chest cavity. Disorders can be broadly classified into problems with its innervation, leading to paralysis, or problems with its anatomy, such as hernias or traumatic rupture.
Disorders of innervation leading to paralysis.
If the phrenic nerve, which supplies the diaphragm, is damaged or not functioning correctly, it can lead to diaphragm paralysis. A paralyzed diaphragm sits higher in the chest, reducing the thoracic volume and causing breathlessness. Idiopathic unilateral paralysis, where one side is paralyzed for no known reason, can sometimes be treated surgically by plication.
Plication, what does that involve?
Plication involves surgically stitching the paralyzed elevated diaphragm down into a lower position. This effectively increases the volume of the chest cavity on that side, giving the functioning lung more room to expand and potentially improving the patient's breathing and exercise tolerance.
And disorders of anatomy, hernias or traumatic rupture.
Yes. Congenital diaphragmatic hernias are defects present at birth where abdominal contents can push up into the chest through weak spots in the diaphragm that failed to close properly during fetal development. The source mentions two recognized congenital sites, figure 60.28, the foramen of Morgagni, which is an anterior defect, and the foramen of Bachdalek, a posterior defect, also known as a pleuraperitoneal hernia. Acquired hernias are usually due to significant trauma causing a rupture.
Traumatic rupture of the diaphragm from blunt trauma.
Blunt trauma, like a severe impact, can cause the diaphragm to tear. The management depends on the severity of the associated injuries and whether abdominal organs have herniated into the chest and are causing problems like severe bleeding or strangulation.
Okay.
If there are severe associated injuries or the patient is critically ill and ventilated, the repair might be deferred until other life-threatening issues are dealt with or the patient is stable enough to consider weaning from ventilation.
How is a ruptured diaphragm repaired?
Surgical repair is necessary to prevent abdominal contents from moving into the chest. The tear in the diaphragm is usually repaired by sewing the edges back together, primary closure, or by using a mesh patch, particularly for large defects or if the tissue is poor quality. This repair is often performed via a thoracotomy approach to gain access to the diaphragm from the chest side.
Finally, disorders of the chest wall itself. Tumors here.
Tumors can arise from any component of the chest wall, the bone, ribs, sternum, cartilage, or the soft tissues. Their management principles are similar to tumors elsewhere in the body, involving diagnosis, staging, and surgical removal if possible. Specialist thoracic surgical input is needed if the tumor requires a major resection of the chest wall structure itself and subsequent reconstruction to maintain chest wall stability and protect the underlying organs.
Other chest wall diseases are often congenital abnormalities.
Yes, many congenital abnormalities of the ribs or sternum are minor and incidental findings, like a bifid rib. However, there are some more significant exceptions.
Cervical rib and thoracic outlet syndrome.
A cervical rib is usually not a true rib, but a fibrous band or incomplete rib originating from the seventh cervical vertebra in the neck and attaching to the first thoracic rib. It's often asymptomatic, but the subclavian artery and the brachial plexus nerves, the bundle of nerves supplying the arm, pass over this area as they exit the neck and enter the arm. Compression by the cervical rib or associated fibrous bands can cause thoracic outlet syndrome.
What are the symptoms of thoracic outlet syndrome from a cervical rib?
Compression of the lower trunk of the brachial plexus, particularly the nerve fibers from the T1 spinal root, can cause neurological symptoms like wasting of the small muscles in the hand, and altered sensation in the T1 distribution down the arm and into the little finger side of the hand. Compression of the subclavian artery can lead to poststenotic dilatation, swelling of the artery after the narrowed point, increasing the risk of blood clots forming within the artery and potentially breaking off to cause emboli downstream. Diagnosis and management of thoracic outlet syndrome can be complex and are best handled by specialist thoracic or vascular surgeons.
Pectus excavatum, or sunken chest.
Pectus excavatum, figure 60.29, shows the Nuss procedure, is a relatively common congenital deformity where the sternum, breastbone, and the costal cartilages, the cartilage connecting the ribs to the sternum, are depressed inwards, creating a dish-shaped deformity of the anterior chest wall.
Right.
While there's ongoing debate about whether it causes significant cardiopulmonary issues due to potential compression, the disfigurement can cause significant psychological concerns and self-consciousness, particularly during adolescence. Surgical repair is primarily undertaken for aesthetic reasons or if there are clear symptoms.
What are the surgical options for correcting pectus excavatum?
There are generally two main approaches. The open modified Rabich procedure involves resecting the abnormally shaped costal cartilages and mobilizing the sternum to reposition it in a more normal, flatter position. The minimally invasive Nuss procedure involves inserting a curved metal bar behind the sternum, typically using thoracoscopy for guidance to push the sternum forward into a corrected position. The bar is left in place for a few years to allow the chest wall to remodel and then removed later.
And pectus carinatum, or pigeon chest.
Pectus carinatum is the opposite deformity, where the sternum is pushed outwards and elevated. Like pectus excavatum, treatment is usually for aesthetic reasons, often sought during the adolescent growth spurt when the deformity becomes more prominent and potentially causes psychological distress. Most patients are asymptomatic from a cardiopulmonary standpoint, so the justification for treatment is cosmetic. The modified Rabich procedure can also be adapted to mobilize the sternum and cartilages to flatten the chest wall. Surgery is often best delayed until late teens when chest wall growth is mostly complete. For younger patients with a more pliable chest wall, an alternative non-surgical treatment is wearing an external orthotic brace designed to gradually remodel the chest shape over time.
Wow. We have journeyed incredibly deep into the thorax and chest surgery, covering everything from the minute details of lung development and pleural fluid balance to complex cancer staging, intricate surgical techniques like sleeve resections and VATS, and conditions affecting the chest wall itself.
We really have. This deep dive into the source material underscores the sheer volume of detailed anatomical, physiological, and pathological understanding that is required to be truly proficient in this field. It goes so far beyond basic concepts, delving into the specifics that are paramount for accurate diagnosis, risk assessment, and planning precise interventions.
And seeing how the assessment of fitness for surgery is such a multifaceted process, combining risk scores, cardiac evaluation, detailed lung function testing of both airflow and gas exchange, and exercise capacity, highlights that it's about evaluating the entire patient, not just the lung problem.
Yes, and understanding disorders like pneumothorax and empyema really requires appreciating the dynamic physiology of the pleural space and the stepwise progression of infection, guiding management from initial drainage to complex debridement or decortication.
We also explore the evolution of surgical approaches, with minimally invasive techniques like VATS and RRTs offering significant advantages in recovery, while traditional open thoracotomy remains vital for specific conditions and trauma. And how surgery for conditions like lung cancer is meticulously tailored to the specific tumor type, stage, and the patient's physiological reserve, with a constant tension between radical removal of disease and preserving essential function.
This level of intricate knowledge and procedural detail, from understanding the precise location of the neurovascular bundle under a rib to the complex choreography of a vigorous cough, truly illuminates the sophisticated nature of surgical practice in the chest.
It makes you think about how surgical science is constantly pushing the boundaries, refining techniques, and integrating deeper physiological understanding to improve patient outcomes. And it raises a fascinating question. What does this incredible depth of specialization and precision in managing the chest cavity tell us about the ongoing balance in medicine, the need for broad foundational knowledge versus the increasing reliance on highly specialized expertise and technology?
A profound point to consider as we wrap up this comprehensive deep dive. This information isn't just facts on a page. It's the foundation upon which life-changing decisions and procedures are based.
Indeed. A lot to process, and hopefully a robust foundation for you. That wraps up our deep dive into the thorax and chest surgery.